presentation, we have the tooth with some infected pulp tissue and problems with the periapical area. What is important to know about the morphology of that area is that the root canal system and the periodontium communicate through natural and artificial kind of the iatrogenic pathways. The pulp tissue is encased in the root canal system, is surrounded by dentin, and communicates with the periodontium through the apical foramen and occasionally small channels known as accessory or lateral canals. You can see also that ones in that picture. Sometimes also in some kind of the iatrogenic pathways like perforations, which can be done during the treatment accidentally, of course. In addition, also removal of enamel and dentin by decay or by traumatic injuries, as well as a cementum removal of during the procedures of the periodontal treatment, they may result in a communication between the root canal system, the pulp, and the periodontium. We have some natural pathways for the bacteria to enter the root canal, from root canal system to the periapical area, and these are apical foramen. So these are the main pathways between the root canal system and its contents and the periapical tissue. So the cementum and periodontal ligamentum, and of course bone of alveolar. Apical foramen is initially very large, but during the maturation it gets smaller, and during the whole patient life it gets smaller and thinner, so that way it can be very thin, but there is good communication between these two areas. We've got also lateral canals, so these canals you can see at the picture. They can be at almost every level of the pulp. Here, sometimes we've got also some additional canals which are directly from the pulp, from the floor of the pulp chamber up to the periodontal ligamentum at the area of the forcation between the roots. We've got natural way through the dentinal tubules for the bacteria to enter that area, and through the dentinal tubules, for example, from the uncovered part of the dentin, especially in elderly people or in patients who have some problems with the some periodontal problems and have recession of the gingiva. So gingiva is much closer to the apical area. Some part of the dentin which should be covered with the cementum is uncovered, because cementum is rather area of and tissue of the tooth which is not so hard, so can be removed during the brushing procedures even. We've got some ways for the bacteria to enter, but also not only bacteria can cause some problems with the periodontal or periapical area. There can be also bacteria which are primarily connected with the periodontitis, and through the gingiva sulcus or that gingiva packet, then can enter the area of the periodicular part of the tooth. From the cause that we have that can cause some inflammation of the periapical, that can cause some inflammation of the periapical area, that can cause some periapical diseases. We've got this inflammation causes connected with the bacteria, which can enter by this through many ways that I just showed you or explained you. But also we have some other causes. For example, some mechanical trauma. This trauma can be connected with some avulsion of the tooth during some even sports. So with that, it can also cause some problems with the periapical diseases. We can also observe periapical diseases which can be caused by chemical factors, and these can be connected with some, for example, medicines that can be were used in previous years during the treatment of the teeth, or it can be some even antiseptics that can be used there. We can have also some thermal factors, for example, like condensation of the hot gutta-percha during the treatment of the pulp infection, and when we're doing the obturation of the root canal, when that heat is too high, but the temperature of that gutta-percha is too high and it's prolonged, then it can also cause some periapical diseases. And of course, the main factor that we observe is because of the pulp inflammation that through the connection with this periapical area can spread to that part. We will move to the part that I finished last time. I'm not sure if I can do it in any other way than just click, 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 so sorry. And this is the thing that was discussed last time. I need to go to page 31, and then we will have this diagnosis that are connected with the periapical area. What we can have as a diagnosis? We can have normal periapical area, we can have acute apical periodontitis, chronic apical periodontitis, chronic apical periodontitis but with symptoms, we call it exacerbata apical periodontitis. We can have acute apical abscess, chronic apical abscess, and condensing osteitis. So we will move one by one to all of them. For the normal periapex, we won't see any symptoms. We won't see any changes at the radiograms. There will be nothing visible there. For the pulp tests, if everything is okay, they will respond normally. For the periapical test, this area will not be tender for the percussion or palpation. When we have acute apical periodontitis, as a symptoms we can observe pain on pressure. At the radiograms, usually we do not see any periapical changes. For the pulp tests, during checking the pulp vitality, we will observe some symptoms or not, depending on the pulp status. And for the periapical tests, we will observe tender to percussion and or to the palpation. This can be caused, the state can be caused by, for example, high restorations. For example, if the patient had some tooth revealed at some visit and comes after 2 or 3 days saying that the tooth is sensitive for the percussion, patient cannot close mouth without sensation, it can be that state, acute apical periodontitis. Usually this what we should do is to take this biting paper, we asking patient to bite, and probably we will observe some points at the new filling which are too high and which cause this state. If the patient have traumatic occlusion, so if there are some teeth which are in a trauma contact with other teeth, then also patient can observe, we can observe, patient can of course report that sensation. During orthodontic treatment, because it's complicated treatment, movement of the teeth are involved in that, then also we can observe that state. In a cracked teeth, this is something different, but if we will have some cracked tooth or partially cracked tooth, then we can also observe that kind tender for the percussion of even for the palpation. We only ask patient to bite or to close the mouth to check if they can feel something during just biting, and for sure they will feel something. If we want to check that we are not sure which tooth, we can use some special instrument like a slough, for example, to place between the teeth, upper and lower, and to ask patient to bite. That way it will be easier to find the tooth that causing that sensation. Or we can, instead that we do not have something like that, we can ask patient to bite on the saliva ejector tip, for example, or even for cotton roll, and usually we will be able to find the proper tooth. If the patient have vertical root fractures, that state sometimes can be visible on the radiogram, but that visibility will be after some time usually, and it's connected with kind of the J halo at that X-rays. Periodontal disease also can cause this tender for the percussion, especially when we observe some mobile teeth. And maxillary sinusitis, if the patient got some problems like that, also teeth can be tender for the percussion. Of course, it will be connected with the upper molars, premolars, and these which have tips of the apexes of the roots connected with the sinus, maxillary sinus, usually. And this can produce some response. For chronic apical periodontitis, patient should not tell us, report any symptoms. Usually this is the thing that we will see on the radiogram. If we're doing some panoramic X-rays, for example, then it's possible that accidentally we will find something, some teeth with some periapical radiolucency, which do not have any symptoms that patient report. They do not react for any pulp tests, and they are not tender for the percussion or for auto palpation. So that cases are cases which are not really rare, and we can find them during kind of the checkups with the radiograms. Chronic apical periodontitis with symptoms differs from the previous one because patient can feel pain on pressure. We can see some, of course, periapical radiolucency. We do not have any response for the pulp test, but this tooth can be tender to percussion. This is the difference only between this chronic apical periodontitis with symptoms and that one without symptoms. Usually is that the chronic apical periodontitis can evolve to this one with the symptoms because of some other factors that can affect that. Acute apical abscess. Here we've got simple symptoms which are really visible because we can observe some swelling and we can observe patient can report some severe pain. On the radiograms, we will observe or not periapical radiolucency. It depends on the state of this acute apical abscess. For the pulp test, there will be no responses, and for the periapical tests, there will be a tender to percussion and to palpation. For the chronic apical abscess, the main symptom that we will observe is some draining sinus. We will observe some sinus tract. Usually this is not painful, so only patient can report that have observed something on the mucosa near the tooth, at the area of where the tooth apex should be, some elevation of the mucosa with some kind of the opening through which the pus is flowing, and it's observed by patient, and of course patient can feel the taste of that pus. On the radiogram, we will see some periapical radiolucency, and for the pulp tests, we will have no response, and for the periapical tests, that tooth should be not tender to percussion or palpation. For condensing prostatitis, and the symptoms can be variable. For the radiograms, we will see increased bone density. So on the radiograms, some parts will be more white. For the pulp tests, it depends on the pulp status, and for the periapical test, we can observe or not this tenderness to the palpation and percussion. We need to think about treatment, how we should plan it and what should be done for that patient. Our decisions should be based on many factors, which are pulpal diagnosis, periapical diagnosis, and restorability of the tooth. So if it's possible to restore tooth properly, to be able to maintain its main function, so this function connected with the chewing of food. Periodontal considerations also should be taken into consideration, and difficulty of that case, and of course from the patient point of view, financial considerations, because cost of that treatment also can be important for the patient. Everything depends on this, if patient will be able to take all the costs of that. We have to remember not only at this what we will do as an endodontist, for example, but also what should be done with the crown, if it's possible to rebuild it only with the filling, or it must be some post placed to the root canal, and then on that we can rebuild the filling, or we have to do it totally with the prosthetic parts like prosthetic post and crown. So it will be different for the patient. Of course, we have to look at the cost, but also at this, if this tooth will work properly in the patient oral cavity after that restoration, or if it will be only for kind of the aesthetics. For the treatment planning, we have to do two major decisions. Is root canal therapy indicated, or should I carry out this treatment myself, or should I refer the case to someone else, maybe someone more experienced? And factors that at risk to endodontic cases are some of the patient considerations, some kind of the objective clinical findings, and some additional conditions that we should take into account. From the patient's consideration, we have patient medical history, some local anesthetic considerations, and some personal factors and general considerations. From the objective clinical findings, we have to look at the diagnosis, radiographic findings, pulpal space, root morphology, apical morphology, and some malpositioned teeth. As additional considerations, we should look at that factors. This is what I said, so restorability, if the tooth can be restored properly, if the tooth structure is not destroyed totally, because if we observe that the root part also is too weak and it's really soft during the probing, it's of course our decision in that case should be extraction than keeping this tooth in a patient's mouth, because no kind of the restoration will be for a long time in that area. We should look at the existing restorations also, because they can be in a bad condition, for example. They can be broken, they can be destroyed, they can be with some chips, they can be with some fractures. So this is one thing, and other thing, how deep they go, if they are properly placed at the proximal areas, if there are any overhangings of that restoration. So everything should be carefully checked. We should look at the fractured tooth, because there are many different fracture kind of fractures that we can observe in the teeth. If this will be some horizontal fracture, there is a possibility of keeping that tooth. It depends also at the area that it's observed. If only it's at the region of the patient's crown tooth, of course we can keep that tooth. The crown can be rebuilt with some prosthetic one. But if that fracture will be somewhere at the root, even if it's vertical, we have to look at all the indications and contraindications to keep for keeping that tooth still in a patient's mouth. We should look at the resorptions. This is a huge subject also about resorptions. We should look at that factor, because if there are resorptions, we have to know if we can treat tooth properly and if there is any chance for that that this tooth won't be destroyed or won't be too weak because of the resorption that it's observed in that. Another problem is endoperioral lesions. These are the lesions which are connected not only with the inflammation of the pulp, but also inflammation of the periodontium. So this is a more complicated problem, needs some treatment connected not only with the root canal treatment, but also we should look at at period state, and based on that, what we will observe, what we will check during examination, it must involve some procedures with the period, for example, scaling curettage, sometimes splitting of the teeth to be sure that they won't be mobile. We will decrease mobility of them for the proper level. So these are more complicated states. Trauma, of course, because we will look if the tooth is only, for example, broken, if we can observe only fracture of some part of the crown or the roof, but also there can be some problems with the mobility, some avulsion. So this we should also look carefully at. Another huge thing is previous endodontic treatment, because we should look if that treatment was done properly, if teeth or tooth is root canals of them is filled properly up to the apical foramen, so up to the end like it should be, or if it's too short, or if it's with some if it's overfilled with some material which is at the periapical area, but not in the root canal, which extends through that root canal. Sometimes there are some root canals which are missed, which are not filled, not treated, but they are treated. The main root canals are, for example, in the first upper or second upper molars, where usually we can find two root canals in the mesial buccal root. So it can be seen that one of these is missing, is not filled, not even prepared. Another example is when premolars, especially upper premolars, because these usually can have two root canals and only one root canal can be found and filled, and lower incisors, especially lateral lower incisors. Also, there is a huge possibility that they will have two root canals, and sometimes we can observe that only one is properly treated. So in these cases, we can observe that patient after it seems successful visit or endodontic visit with the obturation of the root canals, coming to the dental office and usually report that something is wrong because still can feel some pain. And this can be connected with some additional or not found proper root canals. And perforations are kind of our iatrogenic causes of problems, because these perforations can be done at almost every stage of the preparation. First, it can be perforation of the crown during the opening, getting access to the pulp chamber, opening of the pulp chamber, and when we're trying to find root canal orifices. So then we can do perforation on a crown area, but also we can observe perforations at the root area, at that part when we may be working with too big forces, for example, too much force, and we can do some perforations at the area of the root canal apex, but also at different levels of the root canal. And here we have some assessment form for that kind of the situation, we are trying to rate the risk presented by each factor as an average, high, or extreme, and a case with all average ratings should be fairly straightforward. So this is that. And factors to add risk to endodontic cases are patient considerations and this objective clinical findings and some additional considerations, and this when we give them these notes from 1 to 3, we can be sure if we should refer a patient to maybe someone more experienced or not. In one or more factors present high or extreme risk, one must plan how to manage the extra risk prior to initiate treatment. So we have to be sure that if we'll start the treatment, we will be able to finish that properly. If we are not sure, or if we do not have knowledge, or if we do not have experience, or if we do not have the proper equipment, sometimes we can need some magnification, we can need some additional extra equipment to find, for example, root canals which are not directly visible with the eyes, but we can see them on the X-rays. So then we have to plan everything like that. We have to look at the presented complaint. For example, had a crown placed about 6 years ago and now, but I have a blister over that tooth. So we should look at the patient's complaint, know exactly what patient wants from us, and we have to look at the dental history of presenting complaint also. The patient reports no pain at any stage. For example, she has noted the blister over tooth 1-6 about 2 weeks ago, and that medical history in that case will be, for example, allergy to penicillin and aspirin upset connected with the stomach, and some subjective history. So we have no subjective symptoms. Patient report present of that blister on gum. And through the examination, we can see for the extraoral examination no facial asymmetry, no cervical lymphadenopathy, no muscle or joint tenderness, and for the intraoral examination, we can see some sinus present buccally to 1-6. And the special tests that we can perform, then this tooth is not tender to palpation. Pus can be expressed from sinus tract. We cannot see abnormal mobility. Periodontal probing gives us the information that we have 6 millimeters, and it is in the 4 up to 5 millimeter range elsewhere. That was distal palatal. And some special tests that we perform, usually we involve in that test not only the tooth that is suspected for something, but also some additional teeth, usually which are next to that tooth. And you can see in that example that we test in tooth 1-5, 1-6, and 1-7. For the percussion, we can observe that all the teeth gives us some negative information. For the thermal, we have normal response in tooth 1-5 and 1-7, but we have no response in tooth 1-6. And when we checking some Next test, we do not have any response in that tooth, and we have some readings for tooth 1.5 and not possible to test tooth 1.7. And we have some preoperative X-ray. Maybe it's not really clear, but you can see that in that area of the sinus tract opening, it was inserted, usually we insert gutta-percha cones, and that way, if we are not sure what is here and why we couldn't check this tests for the pulp test for the tooth, because we have here prosthetic crown at the tooth 1.7. So when we're placing this this gutta-percha point, the tip of that goes to the area which is suspected to be this causative tooth, which caused the problem. And what will be diagnosis in that case? As a diagnosis, because there were no response for the pulpal tests, we will have pulpal necrosis. So for the pulp, this will be that diagnosis. But for the periapical area, we will have diagnosis chronic apical abscess. The main and most characteristic thing for this chronic apical abscess is sinus tract with the pus flowing from that, and to this opening of the sinus tract we can insert some gutta-percha point to make the X-ray and to find the source of the inflammation. So what will be necessary in that case? It will be root canal treatment and restoration. Patient's medical history does not affect treatment plan, so this plan can be done. We have here access and working length. First checking access and working length. Here, this is a very nice example because it shows us that we have two openings here, two orifices of the mesial buccal root canal, orifice of the distal buccal root canal, and palatal root canal. So we've got four orifices in that case. And on the X-ray, this is what is visible. These are small gutta-perchas or files, rather gutta-perchas, inserted to the root canals for checking of the working length. Sometimes apex locator do not show us proper readings, or if we are not sure if we can have some kind of the jumping in that readings, it's better to do an X-ray with the gutta-percha points inserted to the root canals, or with the files inserted to the root canals, and that way we will see directly on the X-rays if we are at the proper area of the apical foramen in each of the canals. And after finished treatment, after obturation, we can see all the root canals nicely filled up to the apical foramen, so up to the end of the existing root canal. In most of the cases, especially in the cases of the pulp treatment, which is not complicated with the periapical inflammation, we're trying to fill root canals directly to the apical constriction, to the apical foramen, because between the apical foramen and this tip of the tooth, we've got some kind of the mixed tissue, which is something between pulpal tissue and periodontal ligamentum tissue. Because of that, it's called mixed tissue, and it is important during the healing process of that apical area. So if the teeth are filled properly up to the end of the root canal, up to apical constriction, that mixed tissue gives us kind of the barrier between this, what is inside root canal, and periapical area, and protects that periapical area against inflammation. So in a summary, we have pulpal diagnosis, which is normal pulp, irreversible pulpitis, irreversible pulpitis, and necrosis. And we've got some periapical diagnosis, which we have as a normal periapical area, acute periodicular periodontitis, chronic periodicular periodontitis, acute apical abscess, chronic apical abscess, and condensing osteitis. To all intent and purposes, a diagnosis of acute or chronic apical periodontitis, acute or chronic apical abscess, and condensing osteitis are associated with the pulpal necrosis. This is worth to remember. And treatment planning. Root canal therapy is indicated in situations in which the pulp cannot recover. So in situations of irreversible pulpitis and pulpal necrosis. If we have situations of the reversible pulpitis, we will, depends on the stage of that, use some different kind of the biological treatment. So we'll use some indirect pulp capping or direct pulp capping, and it depends on the stage. It can be on the pulp chamber, chamber pulp placed, or at the pulp of the roots. And following root canal therapy, posterior teeth sometimes must be restored with the crown. Post may be required if there is insufficient tooth structure to retain a core. Anterior teeth may not require a full coverage restoration. And important things, agreement for endodontic treatment has to be signed by patient before you will start the procedure, and agreement for local anesthesia also must be signed by the patient before you will start the procedure of that. Okay, I will stop that presentation because this is everything from that one. And I will move to another thing. It's not easy because I can't remember what I did last time to show you that. I cannot do this. I wanted to show you my screen, but I cannot. I don't know why. Yes. Right. this. I will try maybe. How should I do that? Maybe this one. Maybe it will work. Let's see. And that one. Okay. No, this is not that one. I wanted to show you, but I cannot find a way to show that. Why is that? I want the screen. How can I do this? I did it last time. I don't know why this not works today. Maybe I will try to. Okay, maybe now. All right. I need 1 more minute. I don't know why it's like that. Should be easy to show you. Okay, now it should. We will see. Anything? Can you see anything, or only the nothing? Only the screen. Why I cannot show you this what I want? Maybe that one. Okay, let's see. No, we cannot see it. Why? Oh. Another way. Okay, it doesn't want to be shown. I don't know why. I had this previously and I cannot do it now. I need to click screen. This is something that unfortunately happening to me. Oh, I will send you that table because I cannot share it. I'm not sure why. Last time, 2 weeks ago, I could share everything. But now I cannot show you. My screen doesn't work. Maybe here. No. Here I do not have anything. Oh, maybe I should open that. Let's see. Let's see if I will be. Oh, no, I cannot do this. Okay, I will just tell you and I will send you some files because I cannot give it to you, show you now. I'm not sure why. I wanted to show you this nice file that is with the diseases and symptoms and how we can treat different states, but unfortunately I cannot show you that. I'm not sure why. So I will tell you and I will show you the file after this. Maybe that way will be better. So for the we will talk about this periapical diseases, main diagnosis, what we can observe on heart tissues, what we can find as a clinical symptoms, and what can be visible on the radiograms, and the way of the treatment that we've got for that. So for the initial apical periodontitis, we can observe on the heart tissue that we have sound tooth. It can be after trauma, or we can observe improper biting. And in that, we will see that the pulp tests are positive. We can observe serious biting pain if we ask the patient to bite. We can observe positive percussion test and possible episodes of forced spontaneous pain. On the X-ray, we won't see any changes in the periapical region, or we can see some only widening of the periodontal space. The way of the treatment in that will be bite correction and periodical pulp tests to check if the tooth reacts properly. So usually we're asking patient to come in 1 week, 2 weeks, and after 1 month to check the pulp. The same disease, so initial apical periodontitis, but if we have as a heart tissue conditions, we have deep cavity, so this can be complication of the pulp necrosis, and for the pulp test, because this is pulp necrosis, we will have negative. For patient will report serious biting pain. For the percussion test, of course, we will observe some reaction, so it will be positive percussion test, and there will be some possible episodes of spontaneous pain, and we can observe lymph exudation from the root canal. On the radiological symptoms, it will be without changes in periapical region or widening of periodontal space, and as a treatment, we will perform antiseptic root canal treatment. The next periapical condition is periapical abscess, acute or asymptomatic abscess. Here we will have as a heart tissue condition deep caries or non-caries cavity or large restoration. And here pulp tests will be negative. Patient will report very serious biting pain. It will be also positive percussion test. Patient will give us a very strong reaction on that test. At the radiogram, we won't see any changes in the periapical region, or we will observe widening of the periodontal space. For the clinical symptoms, some additional things, it's a strong spontaneous throbbing pain. Also, we can observe purulent exudation from the root canal. We can observe pathological tooth mobility, and in periapical area, palpation pain and gingival surface. And in that case, with the periapical abscess, which is acute or symptomatic abscess, we will also observe general symptoms like malaise, fever, and lymphadenopathy. And for the treatment, we will perform antiseptic root canal treatment. Acceptable here is abscess puncture for anatomical foramen. In serious cases, we can prescribe for patient antibiotic therapy. And next stage of that abscess is a subperiostal abscess. As a hard tissue condition, we will see deep caries or non-carious cavity or large restoration, so the same as in previous stage. Here we will have negative pulp tests, very serious biting pain, positive percussion test, very strong reaction one more time. We will observe also strong spontaneous throbbing pain, purulent exudation from the root canal, pathological tooth mobility, in periapical area, palpation pain on gingival surface, and general symptoms like malaise, fever, and lymphadenopathy. So these symptoms will be the same like in the previous stage, like in this periapical abscess stage, but in this subperiostal abscess stage, all the symptoms will be stronger, much stronger than in that previous. On the X-ray, we won't observe any changes in the periapical region, or we will see only some small widening of periodontal space. And what we will perform is antiseptic root canal treatment. We can do this abscess puncture in local anesthesia, and in serious cases, because of these general symptoms, we can prescribe for patient antibiotic therapy. The next stage of this acute or symptomatic abscess is subcutaneous abscess. It's observed in the same hard tissue conditions, so we will find patient with the deep caries, non-carious cavity, or we will have large restoration. For the clinical symptoms, we will have pulp test negative, very serious biting pain, positive percussion test. We will observe still very strong reaction, strong spontaneous throbbing pain, purulent exudation from the root canal, pathological tooth mobility, in periapical area, palpation pain on gingival surface, and general symptoms. And in that subcutaneous abscess, because first we had this Periapical abscess, which goes up to the some subperiosteal abscess form, and then as a last stage we've got subcutaneous, so that one will be more gentle than the other stages. We won't observe any changes in the periapical region, or we will observe only widening of periodontal space, and we will perform antiseptic root canal treatment. We can do abscess puncture in local anesthesia, and of course prescription of the antibiotic therapy in serious cases. Next one that we have is chronic fibrous apical periodontitis. We have here deep caries or non-caries cavity or large restoration as a hard tissue condition. For the clinical symptoms, we won't observe anything. And as symptoms find on the radiograms, you will see widening. Sometimes it's in the form of irregular widening of periodontal space. The therapy that we will perform is for the teeth with the vital pulp that treat the reason of the apical periodontitis. For example, if we will have some improper bite, then we will do that. And if this will be with the necrotic, with the teeth with the necrotic pulp, we will do antiseptic root canal treatment. And for the teeth which were endodontically treated in the past, we should do periodical radiological control or re-endo treatment, because these teeth which were treated before with the endodontic treatment, if we are observing anything on the radiograms and the patient is, for example, for the first time in our dental office, on our dental chair, we cannot be sure if the root canals are filled properly, if everything else is properly, only these observations on the radiograms, then it's better to observe, because sometimes this stage that we can see on the radiogram just taken on the visit can be the stage of the healing of the periapical area. It can be like it's one of the stages of the healing, so observation is important in that. But of course, if we observe that some root canals are not filled properly, then we should do re-endo treatment. Next periapical disease is chronic purulent apical periodontitis. This also is in cases of deep caries or non-caries cavities or large restorations. And as the clinical symptoms, we can observe fistula with purulent exudation and slight pain during fistula formation. And for the radiological symptoms, we will see on the x-rays destruction of periodontal space and bone margin and lack of the inflammation border. Here also we will perform antiseptic root canal treatment. Next stage is chronic granulose apical periodontitis, in other words, periradicular granuloma. The same hard tissue conditions, so it can be in the cases of deep caries, non-caries cavities, or large restorations. There will be no clinical symptoms reported by patient, and at the radiograms we will see oval or round shape periapical inflammation, usually smaller than 8 millimeters, and sometimes with some distinct inflammation border. In that case also we will perform antiseptic root canal treatment. Next periapical state is a periradicular cyst. And here we have packet cyst or truth cyst, and it will be connected also with the same hard tissue conditions, so with the deep caries, with the non-caries cavities or large restorations. And we will usually observe no symptoms, sometimes drawing of neighbor teeth or emphasis of gingiva. Sometimes we can observe pathological mobility of tooth caused by some alveolar wall resorption. For the vital test, usually negative. In case of the large cyst, it can be some positive Smerger's symptom observed, and characteristic parchment crash, so grating sound can be heard. And on the X-rays, we can observe oval or round shape of that periapical inflammation, and usually this is larger than 8 millimeters, sometimes with some distinct inflammation border. And in case of large cyst, occasionally teeth roots are pushed apart, so we can observe that one also. And here, as a treatment, we will have antiseptic root canal treatment with resection or hemisection of the roots or extraction of the tooth. And this condensing osteitis we can observe also with the conditions of the hard tissue, like deep caries, non-caries cavities, or large restoration. Usually we won't observe any symptoms, but on the X-rays we will see distinct inflammation border around the apex, and in that cases we will perform antiseptic root canal treatment. But in all these cases that I told you, we have to do, as always, for the diagnosis, we have to differentiate it with some other states. So we have to differentiate it with tooth caries, we have to differentiate it with tooth trauma, with gingivitis, with some marginal periodontitis, with periodontal abscess, with the pathological tooth resorption, with some tooth hypersensitivity, with sinusitis, with diseases of the TMJs, with neuralgia, or with inflammation of other nerves, atypical face pain, with some heart diseases even, because sometimes infarction can mimic some tooth pain, with some middle ear inflammation, and with salivary glands diseases. What is important also that when we talk about that, why I cannot do anything here today? I wanted to do my camera on and I cannot. It do not respond on anything for me. I'm sorry. My computer maybe, or maybe something else. But what we have to remember is that for the main part of the pulp conditions, so this with the pulpitis, we perform as a treatment pulp extirpation in local anesthesia. So this will be the way of treatment in that cases. But starting from the pulp necrosis, we should perform antiseptic root canal treatment because we have here the situation with the necrotic, so non-vital pulp, and that pulp can be also with the bacteria, so we have to be sure that all the bacteria are removed from the space of the root canals, and pulp chamber must be this. The treatment must be done very accurately and also with help of the chemicals that will eradicate bacteria totally. So, antiseptic root canal treatment in the case of necrotic pulp, especially this what we call wet necrosis or pulp gangrene, so this which is connected with the bacteria inside root canal system, and this should be performed with with the proper irrigation and some medication placed as an intra-canal dressings for a few days to be sure that all these bacteria will be eliminated from the root canal system. For the first stages before this pulpitis, when we have some only reversible pulpitis, then as a way of treatment is indirect or direct pulp capping, depends on the how deep is cavity, if we hurt the pulp or uncovered the pulp chamber or not. So these are the main things connected with the diagnosis and different stages of the treatment. I wanted to show you some nice x-rays, but I'm not sure if I will be able to. I will check one more time, but this is something that my computer don't want to cooperate with me properly, and I don't know why. Where is this? Mm-hmm. I cannot show you that, and I don't know why. I wanted to. Maybe I can. Wait a moment. Maybe I can add something to the chat. And that way, yes, I can add file. Not bad. I forgot to ask you all to write down in the chat part your name, surname, and index number, please. So please do it in the meantime, okay? And I will check if I can. Okay. Oh, maybe I will be able to do this what I want. Nice. Finally. Okay.